So now we're going to get into some fun, I hope, here. Dr. Sclafani, do you want to come on up? And we're going to do debates. I'd like to call up Dr. Bülent Arslan, Dr. Michael Arata, Dr. Eric Feigenbutz, and Dr. Raj Attarwala, I believe. I hope I got that right. Do you want to go back down? Okay, we'll wait till, okay. I'm going to let, when we get finished here, Dr. Sclafani can go ahead and, you can go ahead and go out for lunch. It's the next door, the next room over. And then we are going to start off, hopefully right at 1 o'clock, with Dr. Michael Dakes. So we'll see you at lunch. And the doctors are going to be there, so you can sit down, have lunch with them, and you can have a discussion with them if you want to. Ask them some questions. Okay, okay, it's all about now. 4 minutes, but let's go down to 3. Yeah, we'll have to reduce.
Okay, good morning, everyone. In the professional meeting, in order for us to get continuing medical education credit for what we do, all the speakers have to make disclosures. The purpose of those disclosures are to allow the audience to understand potential conflicts of interest, perhaps some bias that might be involved with the work that's been done. But I notice that we don't do that when we have an audience of patients. It doesn't seem right, does it? So I'm going to make a disclosure, and I would like you all to make a disclosure as well. Not to say that anybody has any bias, but I think let's get it out in the open so that everybody knows. So my disclosures are that I work for Fresenius Medical Care, and this is a commercial company that provides predominantly treatments for vascular access in hemodialysis, but also has as part of its portfolio of treatments the treatment of CCSVI. My other disclosures are that I do not treat multiple sclerosis, but I do treat CCSVI. Okay, so what we're going to do now is have 2 debates. These debates will have 3 minutes for the proponent and then 2 minutes for a rebuttal. And I don't know if this will work, but we can try it. Now we can have a show of hands beforehand and then see if we can at least get a sense if anybody's been swayed by the debate. So the first debate will be about, is it or is it not, is CCSVI or is not CCSVI all about valves, or is there anything beyond the valves that needs to be considered? On the pro side, Dr. Michael Arata will argue for this being all about the valves, and Dr. Bülent Arslan will speak about that it's not all about the valves. So can we have a show of hands in the audience? Who believes that this is all about the valves? Okay, who believes that this is not all about the valves? Michael? Come on up, Mike, because, you're on now.
Okay, and I'm going to be keeping the time here, so you all are on a clock, okay? You're going to start out, we're going to bring you down to like 4 minutes starting out because we're running a little bit behind time, okay? All right. Thank you. I'll go on down. And I'll stand up when you're out of time.
Okay. Okay, well, I'll start out with disclosures. First of all, no financial relationships to disclose. I'm going to one-up Sal. Not only do I treat CCSVI, not MS, but I only treat CCSVI. All right, then my last disclosure is going to be that what I'm going to be talking about here is not based on scientific literature. There really is none regarding the valves. Okay, well, with that in mind, we can all agree on the fact that CCSVI is a flow disturbance in the jugular and azygous system. And at its surface, if you were going to look at patients and trying to identify whether they have this condition, at least from a diagnostic perspective, you would look for narrowings in the veins themselves, whether it's a CT venogram, whether it's a venogram itself, MRV, etc. That's what you would do. Well, interestingly enough, if you diagnose someone with CCSVI clinically, you're not going to find that in the majority of patients. So what is going on? Well, being sort of interested in the treatment of CCSVI, I look at things from the treatment perspective. And we can actually break down CCSVI into 4 categories based on the type of treatment and actually some prognostic indicators based on that. And those categories are, number 1, valvular CCSVI. That is the most common. And fortunately for that fact, it is the easiest to treat and gives the most durable result. So valvular is number 1. Number 2 is restrictive. Now, restrictive actually helps my argument, because what restrictive is patients who don't have valves. The area where the valve should be doesn't develop, and it actually is narrow. So if you want to call it a true narrowing, so be it, but it's actually valvular in nature. There's just no valve. They, unfortunately, don't have a good result because we do what's commonly known as venous angioplasty, and we've known for decades that works about 50% of the time. I like better results than that. So I hope to have some ideas from the people here that are doing this treatment to identify what is out there as possible treatments for patients with restrictive type. Next is compressive. Now, compressive CCSVI on imaging will create a narrowing, but it's not a narrowing from the vessel itself. It's the outside space, the organs around it. Most commonly, we see stylocervical compression in the upper jugular. You can see omohyoid muscle compression in the lower jugular. In the azygos, you can have compression, or in the hemiazygos. Now, we may be able to treat that from a procedural perspective. It's soft tissue, but if it's bony in the stylocervical area, we actually cannot treat it endovascularly. And the last type is what I call inflow. Now, inflow CCSVI is from many different factors. Most commonly what we see is agenesis or hypoplasia of a sinus or the jugular itself. Fortunately, this is very rare because I don't know of a treatment for it. So the prognosis obviously is not good if that's the type you have. So to support my argument that this is a valvular disorder, I'd like to draw upon our experience at our clinic. And over the last 2,000 jugulars treated, we've only treated the valve. And we have seen no decrease in the results. So CCSVI, at its most basic form, is a valvular disorder. It can have different morphologies. You can certainly see the most common, which is a static or fixed valve. Or you can see derivations of an abnormal valve, which are things like septations, actual duplications of the jugular veins, webs, synechia, things of that nature. Or you can see a maldevelopment or lack of development of the valve. And that's what I consider the restrictive type. If you have that type of anatomy, you typically will have a very small orifice where the valve enters into the chest. That does create a narrowing. And again, I will ask all my colleagues out there, if you know of a way to treat this better, please share it with us, because this is a very frustrating type of CCSVI. And then again, I'll just make one more point about the compressive. With compressive CCSVI, we have options, whether it's physical therapy or perhaps at some point in the future a surgical option. But if you have this type, there is hope for you also.
Can I have the slides, please? So, again, in part of the talk, Dr. Arada also agrees that CCSVI is not all about the valves. It's just that when it's not about the valves, it's kind of harder to deal with. When it's about the valves, it's relatively easier to deal with. And I'm going to show you just a couple of cases quickly and then hopefully go over. Okay. All right. I hope you have a sense of humor, Dr. Arada. Again, as I mentioned before, his task is harder. I don't think he would have chosen this task voluntarily, but apparently he did. He's defending not treating the vein just the valve. So that's, if you aren't going to treat the vein, you might as well be a neurologist. But so, no pun intended. So, and I do actually work with neurologists, so we used to have the best relationship. So, no bad means. So my goal is not to show that the valves aren't important. They are very important. They're where most common blockages are. They're relatively easily treatable. I wish I always, just saw the valves that were a problem. It would make everybody's life easier, and I would get better results for the patients and give better news to them. So venous blockages has been shown to be at multiple levels, just like explained by multiple experts already. You can have bony compressions, you can have soft tissue compressions, the carotid artery can compress the jugular vein, you can have a lot of issues. So this is one case, a 44-year-old male with headache, fullness in the face and neck, has plaques, and the MRI diagnosis of MS. Major symptom is inability to lay flat for more than 30 minutes. He gets fullness and headaches, etc. He can't sleep, neither can his wife. So this is the venogram. A very nice focal stenosis right at the level of the valve. Everything else is great. You angioplasty, great outcome. And the other side is bilateral, so he doesn't even have a backup. Both sides are very tightly narrowed. Very good result. It's a 45-minute procedure. I wish they were all like this. It's no problem. His symptoms improved immediately. During recovery, for the first time, he was able to lay flat for 3 hours. Unfortunately, he didn't get up because he has a groin puncture. So, great, perfect. But the valve actually does not carry the blood. Okay? Its function is to facilitate and help the vein to carry the blood. When it's abnormal, non-functioning, then instead of helping the blood flow, it becomes an obstruction in the blood flow. It's only one of the several reasons, as I mentioned before. These are a list of several other regions that could be causing a blockage in the veins. And there are probably things that we still don't know. So here's another case. A young male, 34-year-old, he's in a wheelchair, has lost significant weight due to choking and difficulty in feeding. His arms, his legs, his hands, everything is contractured. He's essentially wasted in terms of weight. And he has a slurred speech. I could not even understand him. His wife kind of helped me to communicate with him. Severe headaches every day to the level that he had to scream. So this is kind of the worst case I ever treated, and he was my 5th patient. So, and I measure pressure gradients, and there's a lot of criticism about not doing the pressure measurements by Neurology Society. And this patient was 18 millimeter mercury, which is very significant even for arterial bed, but he had this gradient in the venous one. So quickly, left side, there's several stenoses, small vein, and the other side, he has this blockage. So right there, more than half of the vein is blocked. I angioplasty, nothing happens. And so regardless of the cause, what we do is we stented this one. Angioplasty, no result. Stent, excellent result. All the collaterals are gone. His symptoms have improved dramatically. 15 months, he hasn't had a single episode of headache. And other than that, he started to eat himself. His contractures in the upper extremity opened up. He gained 20 pounds in the first 2 months. So if it was all about the valves, this patient wouldn't have been, and that's his azygos, which also had a stenosis in a non-valve area. So if it was all about the valves, this patient shouldn't have been treated. And I do not agree with that. I agree that valves are the majority of the problems and they're very important, but there's going to be patients who will need treatment in other areas. And I hope that they're not as common, but it's all about the blood flow, not just the valves.
Okay, so we're going to have to make 1 minute only for rebuttal. My first rebuttal, I get to rebut everybody if I want. If this is all about the valves, then you should have to do intravascular ultrasound on every case because you can't see the valves by looking at the contrast most of the time. You can see stenosis, but it's not that common to see the valve. On the other side of it, Arslan, the veins do not go into the head. The veins come out of the head.
Well, I've been compared to neurologists. I concede. All right, well, obviously the deck is stacked against me, but I would like to point out that my worthy opponent showed examples of compression, and those are very infrequently encountered. So the majority of CCSVI is in fact about the valve. It is the valve. It's a valve problem. End of story.
I essentially agree. One thing about Dr. Scalfano's comment, IVUS is very important. I don't use it on a routine basis. I think if you do have the right size of equipment and the right size of protocol to obtain a venogram, you can, with the fast rating and amount of contrast adjustment, you can pretty much see, in my opinion, every blockage if you do the right study without the help of IVUS. But if you don't have the right equipment, if you don't have the right sequence, if you're not familiar with how to do a venogram, there's a good chance that you will miss a lot of lesions.
Okay, now, so let's have a show of hands. Who believes it's all about the valves? You lost, Mike. No, you didn't lose because they don't agree with you, but you lost people who agreed with you. To rebut Arslan, in truth, Arslan, in a review of a randomized group of patients with Azygos disease, 25% of the patients we could not identify valves on venography at all, and they were in crazy locations. So anyway, thank you. That was a good debate. Well, this is an interesting one. Is ultrasound an adequate preoperative evaluation for CCSVI? The pro is Eric Feigenbutz, and on the opposite is Raj Adawali. So before you give your argument, you can. Yeah. Who thinks that ultrasound is an adequate preoperative assessment for CCSVI? No, is it inadequate? It doesn't have to be the best. It doesn't have to be anything. Except, is it adequate? Okay. Thanks.
Thanks for everybody for coming. I need to clarify something. I'm not a doctor. I'm an ultrasound technologist with Arizona Doppler Specialists. I have a slideshow that I'd like to go over with you. Is ultrasound adequate pre-op for CCSVI? I think so, but that's your decision. Next slide. The advantages of Doppler ultrasound. The ultrasound is cost-effective. It's non-invasive. There are no shots, needles, or dyes associated with the CCSVI Doppler. It's very high resolution. We can see inside the vessel, we can see inside the valve, or at the valve, or the different abnormalities within the vessel. There's real-time dynamic information that we can see with the ultrasound. As the technologist has his transducer on your neck, things change. And the test can change to look at these different dynamic changes that may happen during the ultrasound. Another benefit is the patients can lie down, or they do lie down for part of the testing, and they sit up for the other part of the testing. There can be a significant change, and there should be, of blood flow from when you're lying down to when you're sitting up. That's something that we've seen frequently with our Dopplers. We're sensitive to detection of flow changes, whether that's a very minuscule flow change or a significant change. We're very sensitive to the different direction and velocities and amount of blood flowing through there. The intra and extraluminal abnormality detection, we can see very well Again, I'm not a doctor. I don't do the angiographies, but I know that I can see the valve with ultrasound, and we see it all the time. Whether it's a septum, whether it's a malformed valve, whether there's webbing inside that vessel, our machines are sensitive enough to look inside there and actually see what is happening and where the blood is flowing faster or slower or not flowing at all, or even in the wrong direction. We can control of respiratory phases during that testing. The blood changes with inspiration as well as expiration, and we note that in our testing. Some of the views we look at are inside the brain, and that blood can change with inspiration and expiration. When it does, that's an abnormality. We can see, we use flow and velocity studies also. In my expertise opinion, ultrasound is a great diagnostic tool for CCSVI preoperatively. Next slide, please. There are obstacles with Doppler ultrasound too. Standardized guidelines, that's something that has to happen. It's something that we have to get together and everybody follow so that we're consistent with what we report with our Doppler ultrasound. Reader and operator dependence. I think that's the most important thing, and that's the biggest hiccup with ultrasound amongst the professionals that don't like ultrasound for diagnostics. I've been doing ultrasound for many years, over 15. I've been doing CCSVI Dopplers for over 2 years now, and I've been doing them well for a year and a half. After I was trained the proper way to do the CCSVI Doppler, I noticed that I looked at blood in a different way, a way that we had never been trained before. Many of you have gone out and had Dopplers to diagnose CCSVI. You may have negative results on a Doppler that lasted maybe 20 minutes by someone very qualified to do vascular ultrasound. Unfortunately, without training, they're not qualified for CCSVI detection. A couple quick more notes. I just want to show a movie. Next, please. This is what we're looking at. You can see the valve bouncing. Can you play that again? See that valve bouncing? That's a septum in that patient's valve that's causing a flow disturbance. We can see it with ultrasound. Next picture. This movie here, you can see that white echoes the blood, possibly some lymph, flowing from the right to left. That's flowing from the chest up to the brain, flowing in the wrong direction. The interesting thing with that slide is that patient is sitting up. That patient is not lying down. The blood is actually flowing up their jugular vein when they're in the sitting position. I don't know how that happens, but it does. It's a pressure change. Blood flows from low pressure to high pressure, or high pressure to low pressure, and that's where that comes from. Thank you very much.
Sorry, I didn't say his name right, poor guy, so Atarawala?
Perfect.
Thank you.
All right, can I get my slides, please? So I'm Dr. Tarawala. I'm a radiologist as well as an engineer. I'm from Vancouver, Canada. And let's see if I can get this to work. So basically, I have no financial disclosures. I only have one disclosure, and that's the fact that I love engineering and I love MRI. So the next thing is, MRI, I feel, is the most useful tool to assess the structure of the brain and to assess for MS plaque burden. It's really the only imaging tool that can be used to establish a difficult diagnosis of MS and monitor response to treatment. It's the de facto standard. So I'm going to step back because, as I mentioned, I love science. So what is a CCSVI hypothesis? People have talked about it, people have alluded to it, but nobody's actually really sort of said what's going on. And basically, what I think it actually is related to is I think it's actually likely related to increased vein outflow pressures in the jugular or azygos vein, or pretty much any vein. And what that results in is that you actually get increase in the Starling back pressure, not reflux, that actually damages tissue around the venules. So those are the small veins in MS. And I feel that it's actually best assessed non-invasively with MRI. And I actually think MRI data is actually pivotal for research assessment. So, oh, actually got the wrong set of slides. This is for tomorrow. This is the more advanced stuff. Okay, so I got to keep on going. So this is a. Can you put in my other set of slides? This is the wrong one, but I got to keep on going. So anyhow, I'm going to have to try and modify this. Sorry about that, but basically, what's actually going on is to compare ultrasound and MRI. What we think is actually happening is that you have arterial flow. Can you guys switch my slides and I'll keep talking, or can you guys switch my slides to the other presentation? So I'll keep on talking. So basically, with MRI, some of the things that we can see is if we say that this whole thing is a vein problem or is actually a back pressure problem, some of the things that MRI can actually do is we know that pressure drives flow. And so the whole question is we cannot measure pressure under any circumstance. So therefore, we have to actually infer what's going on with pressure. And the only way to really do that is with flow. All right. I don't actually have it with me. Okay, so these guys don't have my talk. So I'll have to wing it. All right, so too bad you guys don't get to see the mathematical equations. Sorry. And the funny thing is I actually asked these guys if they have my slides. Oh well. So basically there's an equation called the Navier-Stokes equation that also came from Italy that actually describes how we can take pressure and flow and actually calculate exactly what's going on. The problem with the veins are that the pressures in them are so low that they can't adequately be measured. So if we can't measure them appropriately using a catheter inside the vein, what can we do? The only thing we can actually do properly is model it with fluid mechanics. And the best way to actually model that is using data that we get from MRI. And the way we can actually do that is we can look at flow quantification. Everyone's talked about flow quantification, but pressure drives flow, so therefore we actually can use that technique to calculate exactly what's going on and really understand the pathogenesis behind what's happening with CCSVI, because right now it's completely unknown. And that's probably the biggest problem that we actually have with CCSVI, is that nobody really quite understands the pathogenesis except one man over there, Dr. Schelling. And MRI can actually expand that non-invasively so we can understand where we need to go for directions for research so that this whole question about what is happening with CCSVI can actually be understood appropriately. Because one of the things that's great about mathematics, particularly fluid mechanics when applied to the body or any flowing body, is that you can understand exactly what's going on, you can reproduce it, it is robust, it will be valid here in Orlando, it will work in Vancouver, it will work in Italy, it will work anywhere. It's not dependent on the operator using it, it's dependent on the machine being applied, in which case this is an MRI. MRI is basically a tool that you can effectively plug in different programs, so you can actually look at a T1 sequence, which is looking for one thing. You can look for a GAD enhanced, where you're actually looking at blood vessels and where you can actually see the leakage of the blood flow. You can actually look at FLAIR, where you actually see the lesions as well, and you can look at flow to calculate what's going on. And so the former two, outside of flow, are what your neurologist wants to see with MS. They effectively want us as radiologists to go and count lesions. And when we count those lesions, that's all they're interested in. And so if we have a baseline of what's happening before, then people get treated, and we actually see, has that baseline stayed the same? Has their flow changed at all, independently, here in Orlando, in Vancouver, in Italy, anywhere? It is reproducible and therefore a robust technique. So that's all I have to say.
I like being a moderator because I can just stop it all. So who thinks the ultrasound is the optimum or the best screening tool available? What was the question again? Is ultrasound adequate as a preoperative evaluation? Is it? Who says it's not? Okay, well, let me tell you how it really is. A screening tool needs to be fast, universally available, inexpensive, and easily differentiate people who have the disease from those that don't. Neither one of these tests does that for me. As far as I'm concerned, the screening test for CCSVI is a combination of venography and intravascular ultrasound, because there are patients on both ends of the spectrum that don't get met. And both of those tests have really good value, but not as a screening test. We've got to come up with a better screening test. That's my opinion.